If I could ask our four speakers, Wanda and Eric and Ray and Sonia, just to come up to sit at the table here at the front. And we have now ample time to have interactive discussion and questions. And also, if there's any that people might want to post online, we're going to focus here, but we're going to turn to our panel. But feel free to ask questions of each other. Just because you're up on the panel, it could be that you would have questions that you might want to move forward on. But the first thing, once I'll get you all settled, and I dated myself. I said this is like the Phil Donahue show, but only certain people were able to, of a generation, were able to identify. But if I might, and thank you so much for the thoughtful and diverse reflections that were provided. But if I can pass over and start with Allison first in terms of the particular order to provide, you've had a lot of content provided to you of kind of immediate reflections that you had from your particular position of things that you might learn or take away, and any probing questions. We've got a fair amount of time right now, so feel free to interact. We hopefully will keep questions and comments short to be able to get as much content in as we can. But over to you, Allison.
Thank you all for your presentations. I think some really interesting and challenging ideas. When I look at rural care, one of the things that I think is most important is that team-based care. But I think about the team different than, say, you described, Eric, where it was a single physician with the team surrounding them. I see that team as the place that the patient connects. And because you have a team, it allows members to come and go from that team while maintaining that continuity for patients. It's not the continuity to one provider that we see in the research. How do we scale that to be able to provide the expertise that we need closer to those teams?
Thanks for the question, and I think you and I are quite aligned in how we should be viewing the team. I was reflecting how it often is, and in our workforce work, we often think about replacing that physician or that nurse practitioner or midwife or whoever with another one just like them, doing all the things that we've traditionally expected them to do. And the access points of the future for the different needs of the different parts of the health system that people are trying to access should be viewed, in my view, differently. So it doesn't need to revolve, certain kinds of services need to revolve around the physician who might be remote or right in on site. Certain kinds of things should be centered around the chronic disease nurse, and certain things should be around the preventive or diagnostic sort of capabilities that might be, again, remote or local. So you might have the access point being something that's familiar in a rural environment. It might be your emerge department, but it might be something on your computer or elsewhere where the whole team is there. And I mean, just from a personal experience, I think many of you might have had this experience. We tend to like, and the research has said, you like the continuity. And in our work in the Health Quality Council, we really focus a lot on personal continuity. I saw my physician for sort of some chronic health, normal sort of health things. And once that physician wasn't available, so I saw that physician's partner. And it didn't matter to me because I knew that my record would show my physician when he or she was back, what I had come in for. And I needed to know that somebody on that team was going to sort of understand my history and be able to manage it well and then communicate it back at some point in time. And when we change the climate so that I can trust that the nurse that I see or the physiotherapist that I see or the pharmacist that I see, whether it's at the hospital or in the community or online, can communicate the information appropriately to the next person I see, I'll be very comfortable with our health system.
Yeah, Ray, you just in follow-up?
Yeah, just to add a couple of things, I totally agree with, I think, where both comments are going, and I think really it's one of those mental models you alluded to a little bit in your talk around we define the team usually around disease or profession or whatever, but actually moving to the place where we define the team around the patient. So what is the patient's needs, and then how do we build a team around them? And I don't think it's actually mutually exclusive of a longitudinal relationship for exactly the reasons that you said. And I'll go from a granular and then a kind of a bit of a high-level piece. In our practice, there's a lot of work in BC going on attachment and access. We've been insisting on attaching to a group as opposed to attaching to an individual. But the patient has to be able to choose the provider that they see. And what is happening in our group is patients will, by and large, have a doctor that's their general doctor, or a nurse, or whoever else in the team that's their go-to person. South Central Foundation has some really good evidence around this, and so for some people, their primary point of contact into the primary care team is a mental health worker or a traditional healer or whatever it might be, but they'll have a person. But then also they don't mind for other things to go to see somebody else, and so that choice is super important. What I think is super interesting is actually to get into the driver. So what is driving us to a system that actually that forces that kind of defining a team around kind of a profession or a disease or whatever? And I think there are a lot of them. One of them that we're pushing on quite hard, one of those projects is health data. Because actually there's a lot of people fighting over health data, including industry where there's a lot of money in health data, but there's a lot of territoriality in the health system where doctors want to own the health data, where health authorities or health administrators want to own the health data. And at the end of the day, the law in Canada is that patients own the health data, yet we don't have systems that support that. So I take teams out to Zimbabwe to do bidirectional capacity building work. And in Zimbabwe, one of the 20 poorest countries in the world, they have better continuity of health data than we have here. They have an exercise book, which is torn in half because you can't afford a whole one. And the patient carries it to the appointment. The provider writes in it and gives it back to the patient. And the patient takes it off and carries it to the next appointment. And fundamentally, I think that's one of the drivers, if we can actually move it at a system level to not try and integrate health data anywhere else but with the patient and have patient having control over that health data. The next layer of that, obviously, when we start getting into AI and all of that kind of stuff, is consent. So not only control, but then managing consent as to who accesses the data for what purposes. But they're very pragmatic things, I think, that we can do that will actually shift and drive us in some of those directions.
Okay, Jill, if you had any particular kind of comments or reflections or a burning question to ask.
So I'll start with Ray. You had mentioned, I loved your idea of the edge communities, that it's always been a mental model of my own. If we can fix healthcare for the most underserved, we'll fix it for everybody. But you also then sort of withdrew a little bit from that to say, well, yes, but hub and spoke is there and whatever. But hub and spoke is essentially the urban solution for centralization and the assumption that that's what's cheapest and whatever, when I would think our economist might be on board for saying it's not necessarily cheaper. So how do you see us flipping this mental model from hub and spoke, because it's talked about here an awful lot, to serving edge communities?
Yeah, I think it is a bit of a both and, because I think there are a couple of things that I would say. It's the way I like to think about this is gravitational pull. And the reason hub and spoke models don't work for rural communities is that there are very real things that actually make it easier to kind of do it with bigger populations. So economies of scale, critical mass of services, all of those kind of things happen where you have enough volume, and particularly when we see the health system in the terms of physicality, so who's on the ground. I think we're at a point in our health system, if we are looking to skating to where the puck is going to be, around looking at virtual. And I mean, with low orbiting satellites, we're using them a lot in BC now. Connectivity shouldn't be an issue. Now, wherever you are, even actually mobile, you don't have to rely on your cell signals to do that. So connectivity is one piece. kind of other ways of accessing service, kind of even asynchronous ways of accessing service or other things. So what I would say is there is this gravitational pull that just tends to kind of pull things into the center always. And much the same as, and I shared this a little bit earlier on today, much the same as when we're trying to put a satellite in orbit, we don't complain about gravity and say gravity shouldn't be there. We actually build system forces in place to actually counter those gravitational forces. So that's what I'm talking about, I guess, when I'm talking about the edge first, and I think it's just not ignoring those forces, but saying what we need to do is very intentionally build counter forces to them. So recognize that they're there. We can complain about them, but some of them are just there for pragmatic reasons that we can't change. So then just build counter forces into that. And so one of the things, for instance, would be, and that we're looking at, that we've seen with the real-time virtual support work in particular, is you can potentially get economies of scale by looking at edge communities and actually looking at services that actually support edge communities first. So one of the things that's led to the success of the RTVS work is the culture of the providers. So there's a piece around cultural safety and humility, expectation and training. There's also a piece, and Jill, you'll understand this, around picking up the phone and saying, why are you calling me? Or picking up the phone and saying, how can I help? It's as simple as that. But those things you can actually start building in if you do have kind of a critical mass of services to be able to do that. So I do think it is, rather than saying hub and spoke versus kind of edge first, I think it's a bit of both, but really thinking about terms of in terms of that gravitational pull, and then how do you put counter forces in play to do that. And I also totally agree with you. The other nice thing about the edge concept is innovation occurs at the edge. There's a lot of stuff that rural does very well that urban actually needs to learn from. And so one of the reasons we don't try and separate rural and urban is because there's actually a lot of value add that rural can bring to the urban system, particularly as we're talking about interprofessional and team-based care, because not because we're smarter, but because we have to. We know how you work together. And how you task shift and how you actually do the best you can with what you have. And so there's huge learnings across
And
this.
it's, Ray, I think that's very interesting because internationally, I've been involved in some things and where they talk about reverse innovation, because often they think of innovation coming from the developed countries and kind of being put on to the learnings of the developing countries and people with less resources. And what they're finding a lot is very countries that struggled financially in a lot of ways and didn't build up a significant infrastructure, a health infrastructure, are finding leapfrogging in terms of chronic disease management and able to have a few volunteers, one doctor, and a couple of cell phones in managing a chronic disease management program that isn't as complicated and has really good results. Then we're sometimes burdened by our infrastructure, and so that there's leapfrogs that occur, I think, in some low-resource environments. And often, I think, rural communities leapfrog because they have to solve certain problems, and they do so in a collective way for the communities that they live in to solve, and often move towards team-based care, use of other providers, because they're not having to deal with that competition.
Can I
But it's certainly...
Just ask a very brief comment, and one of the things that we've come across with the language of edge is there's a colonial kind of aspect to that we need to be very careful of. Is that, and so we have heard, and I think a lot of rural people and certainly First Nations people would say is, actually I should be the center, not the edge. And so we don't know what the language is around that, but I think it is important to recognize that is there's a piece around edge being out there somewhere where actually culturally, and actually system-wide, we really need to get to a place where we can actually see equity around the system is built where the patient is, wherever that is. It should be the center.
And just a comment from Stephen.
Thanks. Thank you to all four of the presenters. This was really, really interesting afternoon of discussion. We've heard a lot throughout each of the presentations about rethinking ways in which we organize, finance, manage, and deliver health and health services in rural communities. We've seen the issue of equity in virtually every presentation, the importance of measurement, the importance of understanding what we're doing and the difference that we're making. But from the panel members, I'd just be really interested in from your perspective, what are the key one or two key takeaways that collectively we, through the presentations today, we really need to keep in mind as we leave here and think about improving health and healthcare in rural communities.
You want me to go?
Sure, want to go.
All right. So the piece that continues to resonate with me is around changing the culture. So we have a lot of structural reorganization that occurs from time to time in the healthcare system, is occurring now in Alberta and will occur again. Thinking about how quickly AI is going to come, one of the things that I'm contemplating and discussing as I'm out and about with stakeholders is build some resilience around healthcare system refocusing and restructuring, because with AI coming, this will not last very long. We're likely to have to structure ourselves differently again. And how do we build a culture across the healthcare system with professionals to enable that resilience? And we talk about patient-focused care, and yet the majority of the time that I spend working with stakeholders is focused around the practitioners. And I think there's a real culture change that has to happen, and collectively we need to do that. We can't do that alone as government, that is for sure. So I heard a lot of that throughout the presentations today.
Any other comments from the panelists? In terms of priorities, I might actually just follow up with Wanda. I do think, or in other people, around a real theme is around integration that's required in local communities of shared and approaches to team-based care. There are sometimes barriers in terms of funding flows and services that aren't the doctor payment schedule or the payment for the local hospital. Of those kind of services in between to support team-based care. So I'm wondering about that responsibility, and maybe Wanda, just the challenges that you're going to have to face where we have sector-specific organizations now, and you're the ADM for rural healthcare, but there's rural healthcare in all, you're going to have comrades or people you're having to influence, I think, now in 4 departments, and I'm just wondering, you're thinking about how am I going to approach that particular kind of challenge of dealing with that?
I'm glad that you asked that question, because from my perspective, I don't feel that it changes that much. It's the same people that I've worked with and have had to work with across the sector, whether that was in public health or whether that's with rural health or whether that's primary care, because the lines are very gray in between. And so, yeah, we can structure the system, I think, a multitude of ways. But it's the same people and the same relationships, the same stakeholders that I'll still be talking to, regardless of what the acronym of the various structures are. So I actually don't find it to be that big of a barrier. We've had budgets divided up in a number of different ways, and that's where collaboration happens, is just with building those relationships. And I think Brent can speak to that too in rural health. When he first came into the department, I said, so one of the first things you need to do is you need to get a fleet vehicle. And he said, well, don't you have fleet vehicles in health? I said, no, we don't leave this building. But you're going to get on the road. You're going to go out to rural Alberta. And it's been shockingly surprising, I don't know the words even, to explain how we've been received as we go to rural communities and start to build those relationships.
And Eric, you had a comment?
People want to do the right thing. Most providers and most community members are interested in making their neighbors, their society, helping them be better and healthier and happier and all the rest. And it's no different in healthcare. So, I mean, for me, there's all these impediments that we always, maybe they're bogeyman impediments, I don't know, but we worry about privacy and risks and responsibility being taken on by different providers. The money is important for most people. we need to take care of people. We need to support their confidence to be able to deliver care, because that's their sort of stated mission, whether they're a community member or a health professional. And I always, my watchword always in my head is help me help my patients. What can you do as a government or as a regulator or as an association or a university to help all of us, not just me, but all of us do better for our patients, because that's what our mission is. But man, the language on centering on patient-focused and community-focused, because in some communities it is about the community as much as it is the individual, is just so much healthier. And so that culture shift, once we make it safe, though, for the providers to be able to deliver their care in a good way, and that's all those things we've just talked about, people will rise to the occasion. They'll make that cultural shift. They'll say, yes, this is a better way to do it. The turf battles disappear. All those other things disappear. Now, that sounds a bit utopian. That is the way that we should be going, and using everything that's new at our disposal. If it's technology, it's not to support turf, and it's not to support anything else. It's to support how do we best care for people in the way that they want us to care for them.
And Sonia, I think you had a comment?
I was going to just, can you hear me? Yeah. I was just going to add to that a little bit, in that we're creating some new structures in our system, and there's, we talked a little bit about data being the new dollars in the future, and the comment that strikes as being very illustrative is from a conversation I had with Rudy Doc, Bryden Blacklaws, who you saw on the iPad on that presentation. He said, I can't just go into a community for one shift and keep an emergency department open here or there. I've got to know the community. And it almost sounded like he was operating on the team, or like doing his physician thing on the team. And he needed to see how things worked on the back end, and it was really a very human response that he gave. And I think there's that structure, like if you want economies of scale and you're, one shift here and there, it just might not work if we create that structure. So just not forgetting we're humans is the steer I think my panelists share.
And I'm wondering about what you think are in terms of virtual healthcare, I mean, from comments from anyone who might speak, because it was during the time of COVID was presented of, oh my goodness, given a crisis externally, how rapidly people were able to move. Is this something which is and I've heard two things. One, this is a great catalyst and it's just going to roll and things are going to move particularly rapidly. Or is there a sliding back to particular practices? So I'm just wondering, what are the what's the hope and the promise or the cautions regarding the accelerated use of virtual care and encounters? Is it a great opportunity, or is it one that should be approached with a bit more strategic caution?
Definitely both. Owen Adams sent me a piece that the CMA, the Canadian Medical Association, is working on around what about the promise of virtual care and why is it fading a bit? And there's definite statistics that show how much it has pulled back. When I went to school, so this was a long time ago, and Jill, I won't age you, we were in the same class. You had to examine every patient, and you had to talk to every patient. And for me, virtual care is a real challenge, because when you can't actually connect with a person face-to-face, examine them if it's appropriate to do so, get a good history, etc., you've missed some points of information that the patient might give you that would be critically important. But there are a whole bunch of things that virtual care should do. So why should I force a young mother with 2 kids to take them out of daycare, maybe leave her work and sit in a doctor's office or a nurse practitioner's clinic for 3 hours on a Monday morning when she needs a refill of a prescription that she could do in 3 minutes virtually? And well set up clinics, and there's tons of them in the provinces, will do that. And so it's not one or the other. It's which kinds of services are amenable and maybe better delivered by virtual care, thinking about the patient and their needs, and which kind of things demand or require an person visit. And we can figure that out. We can make those estimations. And if you're in rural and you don't have the opportunity for whatever is the hub of hospital or emergency care to have somebody there all the time, are there ways to help manage it? So in end-of-life care and palliative care, we have specialist palliative care physicians and nurse practitioners who have a 24/7 on-call service for the entire province of Alberta that anybody can call at after hours from any part of the province and say, I've got this problem with this particular patient. I don't know what to do next. Can you give me advice? And that's an example of distributed expertise done virtually, just like telemedicine or telehealth was meant to do, so that we can actually make sure that those expertise resources are available in communities that would normally not have someone with that expertise.
Ray?
Yeah, a couple of thoughts, and I think that linking the last two topics, I think kind of areas of focus, we heard about culture eats strategy for breakfast. Relationships shape culture. And so if you're wanting to shift culture, having wishful thinking about culture is not actually the solution. You probably need to have a line item for a fleet vehicle so that you can, or ways to actually improve relationship is going to be super important. And then, and I think we have a lot to learn from our First Nations partners around this as to the importance of relationship and how you build relationship. And so there's a lot of kind of bidirectionality to that we need to look at. And I think it leads into kind of this piece around virtual. We've actually moved away from virtual care and telehealth. And there are a lot of places that were doing this beforehand. So Carriacou County Family Services in British Columbia was doing it probably for 15 years, whereas a mix of virtual support and in-person care. In the Robson Valley, where I work, we've been doing it for 20 plus years, where we keep two emergency rooms open by kind of overnight, actually supporting each other. So they're not new things. It's just the scale has been the challenge. So I think that the learning in that is actually often it's little things that are going on with the right environment will actually suddenly explode. And then the second piece is we moved into much more into the language of virtually enabled care or hybrid care. And there's a document that John Polovich, who kind of leads the RTVS work, has done for the ministry around principles of hybrid care, which outline, I think, some of the really important pieces. Is it's really about building and investing in what's in community and adding to and supporting what's in community as opposed to replacing something that's in community or something that you need to be there physically with kind of something that's cheaper, because it's probably not cheaper.
And Sonia, I know you've done a bunch of work I was about to say imposing, which is a terrible thing to say, but kind of being involved in execution of digital health, particularly through networks of emergencies around the province. So I don't know if you had any comments about some advice about how rapidly you should move to hop on this particular kind of opportunity, because I think that's sometimes a choice. Should we move rapidly rather than slowly at this point of time in terms of implementation and support for virtual options for care delivery?
I think it's too late. Like the toothpaste is out of the tube. It's a good statement. Virtual care is here to stay. And we won't even be calling it hybrid care in the future. It'll just be how it's done. Yeah.
So, sorry, Allison.
Yeah, I would argue that rapport comes from trust, and it has nothing to do with whether or not you're on a screen. One of the biggest compliments I ever had from a patient I worked with, that I worked only virtually with, was that I made the screen disappear. And I think that came from having a trust relationship with that patient. The patient could bring me a problem. I would do what I could to address it, and I was quite honest with, this is not something I can do for you today. You are going to need to see this provider in this setting who can do that. But I couldn't do that in the first meeting. Like, you have to have that trust there. And that's built to their first meeting, and that can't be over crisis.
Healthcare is about a human connection and relationship. It's not transactional. And we are making it very transactional, unfortunately, and I think that will be to our detriment. There are some things that can be transactional, but as you nicely said, after you've built up that trust and confidence.
Yeah, just comment. I was wondering, because we have 3 physicians here, I think, who I think are known for working with other providers, but there is some situations as we move towards team-based care, what is often referred to as the guilds being possessive of certain scopes of practice as we move to teams. And I didn't know whether you had thoughts on strategies of how to address resistance to changing roles based on technology or other professions being provided. Because as we move towards team-based care, there is kind of pockets of resistance in terms of physician practice, what is kept and owned compared to pharmacists, optometrists, nurse practitioners, that kind of thing. And any kind of advice of how to take that path forward to move on that. And so either of the panelists or Jill.
So maybe I'll start. I think rural never got rid of teams because there were never enough of us, or there haven't ever been enough of us. So someone comes to town with a certain set of skills, well, holy cow, there are at least 1 or 2 practitioners who are only too happy to incorporate them because that's something that gets taken off somebody's plate to do something else would be one of the things. I would argue, and we talked about this a little at our table, is that governments have been very good at dividing us. And that, so the idea, and I think you mentioned it earlier, John, someone else in the panel as well, but this idea that we're suddenly putting shingles up for pharmacists and for nurse practitioners. We finally herded family docs into more team-based care in the city. You can't have independent practitioners and work in teams. So an example I'll use is this was a bit ago, but I'd seen a patient in a clinic, talked to the mom, it was a kid, talked to the mom about the prescription. There had been a change in the dosage of the medication, but the old dosage was just fine. And it was something she was aware of, and she wanted the old doses. So I wrote that prescription. She calls me in a panic because the pharmacist won't give it to her. Well, why didn't the pharmacist call me and ask me why I did that? I mean, so it isn't just a physician who's kind of doing their own thing. It's a whole mess of people doing their own thing, and that's not good for the patient. So I think we actually have to change the words team-based care. That this is the patient's team-based care. Because otherwise, it's just a group of physicians and nurse practitioners and whatever, doing their own thing and seeing people, as opposed to seeing themselves. So I would argue, it doesn't matter to me who the patient sees when they come to the clinic, but they need to know who the need to contact, who the person to get into the team is. And they choose that person, and then that person can then marshal the rest of the professionals. But I think right now we're so focused on the team, and we keep getting stuck on what I do, what Allison does, what the pharmacist down the road does, as opposed to what do you need as a patient.
Thanks, Jill. And I think that is of the other panel, of the physicians responding to the panel, but that is something I know that struck me as often when you said, and here are the members of the team. Often the actual patient family is not included as the person who probably spends the most time delivering care themselves, care of their family. But Ray and then Eric, or Eric, go ahead.
Sorry, I really appreciated those comments, Jill, and it's very true. And if I was government, I'd be really worried about the way we've gone, because we've created all these other practitioners working solo, connected because we've got electronic connectivity to the transactions, to the incidents of care, and we're duplicating services. And they're not always coordinated, and sometimes it hurts the patient. It is very expensive, whether it's privately paid or government supported. We have not done this well. And we see this sometimes in very entrepreneurial environments with certain kinds of businesses, and it is harmful to our society. I think partly it's confusing to the person, to the patient, and partly it's a bit of a battle sometimes around what to do, and it's very, very expensive for society.
But just in my first question had been, how is you as physicians, supportive of moving towards teams, kind of generally in interdisciplinary, deal with, how would you give advice about perhaps resistance in terms of other professional scope of practice expansion that might overlap or impede or deal with it? Just navigating that,
Right.
if there's any lessons of how to go about doing that.
So
actually would be helpful.
it's making things safe first. And so that's why I brought up those examples of the privacy issues. We're just really afraid of privacy, and it actually impedes healthcare often. The risks, who assumes the risk, indemnification, all those kinds of things, and then reputation, and also income. So if we make it safe for people to be able to work in a collaborative way to the benefit of the patient without risking those other things, and there's ways to do that, I believe, then we will dissolve most of those turf issues. There are certain people who we will never dissolve based on whatever we do. That's just their personality. We're not going to change that.
Ray?
Yeah, it's a great question. So pragmatically, so one of the slides that I omitted is the work that we've been doing around collective perspective. So at a planning level, feeding into these partnership tables, we recognize that actually some of these groups have organized structures behind them and some of them don't. And one of them is an rural interprofessional perspective, because it is a physician perspective or a nurse perspective or a physio perspective. And so where do you actually get people together where they can actually share and kick those around? And so we do have Midwives Association of BC and RCCBC host an interprofessional collective perspective table when we talk about these things at a macro kind of provincial level. And I think so that's one place, is in dialogue, creating spaces for dialogue for kind of these various kind of potential team members to come together. And then the second piece is training, our training systems, because we actually, the hidden curriculum is the hidden curriculum and not so hidden sometimes, and it is very siloed. I don't know about Alberta, but in BC it's hugely siloed. So we should be training providers, so skating to the future, we should be training people to work interprofessionally. So they should actually be learning together, and they should be understanding, you talked about that earlier, understanding kind of what each other does, and scopes of practice and all that kind of stuff. And then also in the learning, figuring out, actually, well, that doesn't make sense for me to do that in that context. Maybe somebody else can do that. And then how do we make sure that we kind of understand the way each other works? Would be two kind of pragmatic things that I would say we need to be looking at doing.
Yeah, no, that's great. Are there any particular kind of comments or questions? Elder Cardinal?
Now I know what it feels like to be ignored.
Oh, were you waving at me? I apologize, sorry.
Okay, mine is very simple. I just want to thank you guys. And when I was talking about language, I didn't expect every one of you to be fluent like the way we speak our language. Like when I was saying is to speak to the patient that's in the hospital, is that when I was talking to you and I was just giving you some sample of the words, and maybe just learning how to do the verbs, and then also not expecting them to be fluent with you. But if once you know the verbs, like astam, that means come here, you know, and then tanse, a lot of them use the word tanse. Tanse means how are you? You know, then they can relate to you, you know. And the other one is, do you still go to the reserve? There's still nurses and doctors that go to the reserve. Yeah, I hardly ever go there. Anyway, but that was one of the things I want to thank you, and I'm glad that this is happening, and changing the policies, and then also giving that the respect, you know, because once you give the respect, you receive it. Okay, and then, so anyway, that was the one I just want to clarify on the language part. Yeah, thank you.
And how do you say thank you? Nanaskamon. So, Nanaskamon. Okay, so Ivy, yeah.
Sorry, just a quick plug for something that we developed out of Team Primary Care, because there are no educational programs that know about what each other does. They haven't integrated that. We started with creating a compendium of roles in primary care. It's free to download, and we want to work with anybody who wants to integrate that in like pre-licensure education or post-licensure continuing professional development. So it's a compendium of roles, and each practitioner group developed their entry. It's very short, about 1,000 words per entry. Start with a vignette about, so how is it that, a midwife, works in a team? So all the vignettes are, how does this person, this particular professional role, work in a team? That somebody didn't know. How do you bring in speech-language pathologists, to help people with swallowing, for example? So there were so many aha moments around the table that people just didn't know. It was really exciting. So we have this resource, and we want to spread and scale it. So just wanted to create a plug for that.
It's a pretty cool idea, and being practice ready to be able to actually help your patients access the things they need is how we should be training physicians. So we have this huge opportunity, and Dr. LaFontaine or Dr. Conkin, who have been in the educational system as teachers, will know better than I, but I'm hoping that the two new medical schools in Grand Prairie and Lethbridge will have that as part of their curriculum from the get-go. It's quite hard to change curriculum and entrenched medical systems of training, and so if we can do it from the get-go, that's the way to go, I think.
Okay, thanks very much. And Stephen, I think you had a comment or a question. No, that kind of thing. And so we're going to be just wrapping up before we move to our closing remarks. But I did wonder if people had any kind of last reflections of things that they'd learned today, or some kind of final questions that they might have of each other, of kind of thoughts. One, certainly the cultural change and the flipping of the diagram in terms of the top down, but rather than moving bottom up, is extremely important. And for me, the ability to measure, develop a rurality index, and actually using something consistently and using data to showcase and tell the story about our populations, I think can be extremely powerful. I think some of that information that might be done consistently could assist in driving forward some particular kind of change. But just some last minute reflections that people might have in terms of kind of key reflections that they might have from today. I don't know if any people have them.
My one would be to ask each other, and I'm thinking specifically of government, but it would be for anybody, how do we help you do your job well and make good decisions? And government should be asking us as physicians or nurse practitioners or whomever else, how do we help you do your job well? Because we've each got individual places to play in this grand enterprise that's really, really complex and difficult to change. And everybody's well motivated, and I want to know how we can help government do its job well, and I want them to ask me how I can help them do that job well, how they can help me do my job well, in a sort of reverse way.
And I would layer on to say, and then we collectively need to ask the patients what they expect a job well done looks like too.
Yeah, absolutely. Good point.
A lingering thought about the grow your own conversation we were having, and something about that conversation where you can't go back to your own community because things just change once you go to university, and I think there's something to that we can unpack, maybe thinking like, why is it that somebody gets rejected from their own community after going into medical school for a few years, and how how do we get at that? I think that's a question for you folks.
Yeah, great question. I think one of the advantages we have in BC is the First Nations Health Authority, so which is very different to the rest of the country. They have an excellent program of laddering, and I think it is a variable thing. Sometimes you can and sometimes you can't. It's just, I think the trick is not trying to put anybody in a pipeline that you're coming in here and you have to go out here is going to be the trick, but I think there's the tendencies. From my perspective, really lots for me to chew on and think on, learned lots today and really appreciate being a part of this.
Thanks. And just any last-minute reflections from the reflective panel we had here from Stephen, as from either your role as a senior public servant or as chairing the Imagine Citizens group.
Thanks, John. I think one of the key insights for me today was really thinking about rural, not just in geographic terms, but really in a discipline, as a focus in and of itself. And that starts then with going to communities and finding out what matters to them, what are their needs, and working with them, regardless of that community, to creatively address those needs, but engaging with the community members so that they're part of the solution, not having something imposed on them, but really not just thinking about rural in terms of geographic terms, but in a very, very much more complex and sophisticated way.
And Jill?
So for those of you who know me, you know this is one of my soapboxes, and I haven't brought it up. But I think there needs to be a culture change in policymakers. And I would point at a couple of articles that are hugely important. One called Geographical Narcissism by a Norwegian woman named Malin Fors, who's a psychoanalyst in the furthest north community in Norway. And the other is called Structural Urbanism, out of the States. And it's about how funding actually perpetuates the status quo, why population-based funding doesn't fit with what rural is. And so those would be my final comments, that everybody should read. Fors' Geographical Narcissism, and Probst is the lead author of Structural Urbanism.
Well, thanks. Well, hopefully this boosts sales at the moment from the recommendation. But Allison.
Oh, it's hard to land on just one. There's been so many interesting conversations today. I think taking what we've learned today back to our communities and having these conversations with our colleagues. Unfortunately, we don't all get to be in the room at the same time. And so I think we need to take the information back so that there are more people out there thinking about rural health in a different way.
Okay, thanks. And did you have a question that was online that if you might...
Yeah, so we do have one online question. There have been several references to health equity this afternoon. Appreciating that there are practical limitations to this, and given our geographic spread, to maintain professional competencies, what should be our approach to providing reasonable access to health services in Alberta? Are the promising practices coming out of rural, remote, and Indigenous community engagement activities?
Oh, well, that's a big one. But I think if people might highlight the Albertans who are here, perhaps even Wanda and Allison, in terms of the current ones underway. I know in terms of particular practices to address equity that you might want to highlight. You did some in your presentation, I think.
Yeah, I think there's a lot of different programming that we're introducing, but I think there's also some really practical applications of policies that have been put in place that inherently disadvantage rural communities, and that's one of the pieces that we're digging into with our action plan. This one example that I share is when I was visiting some communities, I went to Claire's home, and they said, "We've been told we will never get a CT scan here." And I said, "So what's the story?" "Well, because we are within 100 kilometers of another CT scan. And so this is a policy, government policy. I said, well, I've never seen that policy. But that's what they were told. And they said, if we were built on the other side of town, we would be able to get a CT scan because we're at 97 kilometers from High River. So, you know, that's just an example of something that doesn't take a lot of effort to change. There's no legislation, there's no regulations. That was just something that has evolved over time probably. And so those are the types of things that we're also really trying to uncover as we travel the province and address. And I believe that they now have a CT scan. After telling the minister that. So just being practical, because the other thing that happens with some of those policies is unintended consequences, which is they said, our ambulance now has to take patients to High River. And as I was driving out of Claresholm that day, I followed the ambulance to High River. So they're without an ambulance if they have to then transport that patient. But again, maybe a more urban-centric policy, small p policy that was developed over time that we can look at changing some of those things.
Okay. And just wanted to, a question Elder Cardinal had, and then Allison, and then we will transition to our closing address.
What you're doing here is totally awesome, and this is something like if you go to regional council or to the chief and council, is to sit down and meet with them and teach them what you just taught me here. You know, and then this way, then they have a leg to stand on and somebody to go and talk to and say, I need, just like what just happened here. And that's just exactly what happened in Treaty 8. You know, they're always, you know, like one is ahead and one doesn't get it. So in Sucker Creek, I'm from Sucker Creek, but I live in Grand Prairie, and there's a competition between Driftbile and, you know, and Gruard, and then here they're only within miles with each other. And yet they can't seem to get ahead. And so if something could happen like this to them, you give them a leg to stand on and to stand for themselves. And, you know, and this is something that needs to, I guess I don't know if you guys knew that. You did? I did. Oh. Well, we need 10 more of you. Thank you. That's just the one I wanted to, because it seems like there's always one group that gets excluded. But if you can say, listen, we can go and speak to so-and-so, and, you know, what is it that you would like? That's why I asked if there's still a nurse or a doctor goes to the reserve, you know, because nothing ever gets told or repeated, or, you know. So I just thought I'd let you guys know. Yeah.
Thank you so much. And Allison, just one final comment in regard to what we were chatting before, and then we'll be moving on. So if you wanted to come back and sit into the audience kind of now, but one particular question.
I'm actually just going to build on what Darlene said. I think there was supposed to be a very exciting conversation to happen at Peerless Trout First Nation about 2 weeks ago. And unfortunately, it meant that most of the people who were attending that meeting from government had to travel to Slave Lake first by road, stay overnight, and then drive 2.5 hours into the First Nation to be there for the 8 o'clock meeting. And so as a result, they made that meeting virtual, which meant that those folks didn't come. Now, at the end of the day, it got canceled because of fire. We can't stop the fire, but I think we need to be a bit innovative about the way that we look at booking those meetings to really get the people that need to be there.
Thank you very much.